So, let me set the stage. This is, I think, a very important slide because we've heard the term artificial pancreas. This is what the real pancreas does. This is what we're trying to achieve. And I can tell you, we will not get an fully artificial pancreas until we have faster acting insulins, because just the fact that we are injecting sub-Q and there's a lag time for absorption, and the absorption isn't always the same, that's a challenge. But we're doing pretty well without matching what's shown in the upper panel here, the insulin and the food. They're very tightly controlled. And just notice that even in people without diabetes, which this represents, you hardly ever get above 140. It's actually rare to get above 140. So we all know why we want to keep the glucose as normal as possible. The DCCT study, everybody knows this slide. All that improvement in the intensive management group reduced the complications, microvascular complications, but there was severe hypoglycemia. And what I hope to show you as with the 780 is that you can get exquisite control without hypoglycemia. Here's the cardiovascular risk, the EDIC trial, same thing. These subjects were 28 at the time and didn't have cardiovascular disease and didn't develop it for the first approximately 10 years. But as time progressed, the intensive management group took advantage of what we now know as metabolic memory or the legacy effect, and had improved or reduced cardiovascular outcomes as a result of that, even though their A1Cs in each group regressed to the mean of 8% afterward. Now, when I went around in the United States asking people, or this was with 670, saying, well, look at the time in range. And particularly the insurance people would give this, what's time in range? We don't know anything about time in range. And we know A1C. Tell us, how does A1C and time in range relate to each other? And so I went to the literature and found 18 randomized controlled trials that were published at the time. This is now over 6 years ago, that were contemporaneous. I just put them on a graph, and lo and behold, a very tight correlation between A1C and time in range. And you see here that an A1C of 7% is about a 65% time in range. Another way to think about this is a 10% change in time in range is equivalent to about 0.8% A1C. Keep that 10% in mind, because you'll see differences in some of these studies I'm going to show you, and how important even a 5% improvement in time in range is from a clinical standpoint. Now, this is a recent study that came out from the Belgian group, de Muemeister, and he said 10% higher time in range reduces the risk of microvascular complications by 17%. So 10% is kind of a magic number, even 5% higher time in range. Now, this is a paper that you may not be aware of, and I think is brilliant. It just came out in January by Boris Kovachev at the University of Virginia and several other brilliant people, including Roy Beck and Tade Battolino. They took the DCCT data, in which everyone did a 7-point profile for a week of BGs, and they did that 7-point profile for a week every 3 months, and the study lasted on average 7.5 years. You can imagine how many thousands, it's over 50,000 points. And what they then did is they trained a computer with machine learning to take all those points and make them into individual CGM. So now you have individual CGM tracings for every person in that trial. And what it shows, and this is the virtual CGM from the DCCT trial. So we know what the complication rates are in the DCCT trial. Can we actually apply time in range instead of A1C? And that's what this shows. The time in range, as it improves going to the right, reduces the risk of retinopathy, just the way you saw A1C, when it goes down, improves the risk of retinopathy. What they also did was look at the hazard ratio. And here's what's really interesting. The hazard ratio for a 0.5% increase in A1C is 1.35 or 35%. Actually, time in range is a better predictor of retinopathy, 1.72 or 72%, almost double the predictability, the hazard ratio for retinopathy. So we now have a tool with using CGM that's even better than A1C in terms of predicting microvascular complications. Time in tight range, which I don't have time to go into too much today, is really trying to get people into normal glycemia, 70 to 140. And that's even a better predictor. That is almost a twofold predictor compared to the other metrics. Now, this was a retrospective look at DCCT. Viral Shah, who was at the Barbara Davis Center in Denver and now is at University of Indiana, did a very interesting study in which he looked at incident retinopathy and looked at the CGM time in range and time in tight range for the previous year. And he compared that to people who didn't have retinopathy at the time. And what he showed is that a 5% decrease in time in range increased the risk of retinopathy, as you see here, by 18%. He also showed time in tight range, if you got a decrease in 5%, increased the risk of retinopathy by 28%. So this is the difference. Time in range is not normal, 70 to 180. 70 to 140 is much closer to normal. In fact, 96% of people without diabetes have glucose in the 70 to 140 range. Now, we heard the term, we heard the term dumb pump. Here's a very interesting graph. So here's the time in range you get with CGM. So this is the DIAMOND study, a well-controlled, randomized controlled trial. Without the BG meter and MDI, you get 44% time in range. If you add CGM, you get a nice increase, but only to 51%. Remember, we're trying to get to 70%, which is what the guidelines tell us we should be aiming for. If you add a pump and CGM, this is what I call a dumb pump, you get a few more percent. If you add a sensor augmented pump that does like the 640, that suspended insulin, you get a little bit more. And along comes the 670 and 770G, the first automated insulin delivery system. This was the first one in the pivotal trial, got above 70%. So 72% and 6.9 A1C. And now here's what you get with the advanced hybrid closed loop, or 780. You get 80% if you use the recommended settings. We saw Jyoti Dev show his patient with 79%. That's what everybody is potentially getting. In fact, I'll show you data about what percent of people are getting these kinds of great numbers. 82. Okay. Wait, I'm getting there. But look at the difference between CGM, 51%, and AID in the 780G, advanced hybrid closed loop. It's almost a 30% difference. This is why I like to say, that CGM is not enough. It's an expensive technology. We're hoping that it will get less expensive. But if you're going to put someone on a CGM, frankly, it's not a waste of money, but look how much better you can do if you have an AID system. A 30% difference in time and range, if you go back to that graph that I showed you, is equivalent to about a 2.4% improvement in A1C. So here's the 780G. I won't belabor it. You've all seen it. And I will say that one of the new and exciting features of this is the extended infusion set, which lasts up to 7 days. There's a filter that filters out all those impurities that develop because of agitation and heat and cold. And it really does work, and people love it because they don't have to change their sensor and their infusion set on different days. I could spend an hour or more on the algorithm, but here's why the results are so good. Because there's a target. We recommend the target should be 100. You could also be 110 or 120, or a temp target, 150 for exercise. But for the most part, we recommend that you use a target of 100. And here's what happens with the system. There's auto basal. Those are the pink bars every 5 minutes. And all those auto basal, every one of those mini boluses is trying to get to the target. In this case, we recommend at 100. If you reach the max basal, which is actually adjusted every 24 hours based on an average of the basal rates and the total daily dose for the previous week, when you reach that max basal and your glucose is above 120, you get extra insulin. And you get that, we call that a correction dose. And you can get that every 5 minutes if necessary. And that correction dose will turn the curve if the glucose is coming up and start to bring it down. So it's the every 5 minutes that's really critical. And you can get as much of that correction dose every 5 minutes as is necessary to get the glucose improved. Now, within that algorithm, there are 3 modules. I'm going to talk about the safe correction bolus module because that'll give you an idea of how this actually works. The safe meal bolus is also operative at all times when people bolus for their meals. And there's a meal detection module that if you don't bolus, it detects that you've had a meal and gives you extra insulin. So here's how the safe correction bolus works. If you see these blue bars, these are the extra correction boluses, and you see these little dashed lines. Those dashed lines can be filled in or reduced depending on safety, the safety of giving that extra dose of insulin. And every 5 minutes, the system goes through a calculation behind the scenes, and it says, okay, I'm above 120, and I've maxed out my auto basal. How about if I give 1 unit of insulin? There's a predictive algorithm that says if in the next 2 hours 1 unit is too much, I'm not going to give that 1 unit automatically. If then it says, well, how about 0.75? Let's cut it down by 25%. Well, if you cut it down by 25%, it's still predicting hypoglycemia. What about 0.5 units? That's the magic number. So it's giving the right amount of insulin safely every 5 minutes. All this is going on behind the scenes, and it's taking into account what the insulin is on board because the previous correction dose puts insulin on board. So you don't know that there was a correction that was given 5 minutes and 10 minutes and 20 minutes before. This is all calculated in the pump itself. So how does this work? So in the United States, we just analyzed this data. This is fresh data as of last month. If you use, this is 110,000 people in the United States who are using 780G. The time in range is 72.7%, but if you use the recommended settings, it's almost 78%. You get an extra 5% using the target of 100 and an active insulin time of 2 hours. Active insulin time is not the physiologic insulin that we know and love. It's actually a lever to make the algorithm more aggressive. So we're getting almost 78% in the United States. Now, there are a lot of barriers, and a lot of the barriers, as we heard, are with us. People who say, I won't prescribe a pump unless patient has carb count. If the A1C is too high, I won't prescribe it. It's really actually those people need it the most. And so here's some interesting data. And I only have a couple minutes left, or 1 minute left, so I'm going to go quickly. This is an age comparison. On the left-hand side are adults greater than 15. We have to use that 15 because of privacy. We cut the data at 15. On the right-hand side are children 15 years or less. Look at the time and range that, with the recommended settings that are outlined in the purple, between children and adults. Turns out, we've narrowed the differences that we've seen traditionally between children and adults because that algorithm is kicking in every 5 minutes with auto corrections and mitigating some of the behaviors that children engage in more than adults, like not taking their insulin, not bolusing, not counting their carbs, not giving their bolus on time. That's all being mitigated automatically. Here's you say, well, this patient needs CGM first. That's a big thing in the United States. CGM first, I think that's common almost everywhere. You don't need CGM first. Here's technology naive youths in New Zealand who were just put on the pump and the 780G. And they went from a time in range of 27%, and this is now 1 year later, and they've maintained in the low 60s. Yes, they're not getting 70%, but they're 27 compared to the low 60s is pretty impressive. These individuals who were subjects in this trial had an average A1C of 10.5%, and it came down to 7.6. And look at the individual A1Cs. Would you put someone on a 780G who had an A1C of 17 or 13 or 11 or 12? We would say, oh, they're not paying attention to their diabetes. They don't, quote, deserve a pump. They're the ones who need it the most. And I think till we get that concept in our heads, we're going to be, it's an uphill battle. And here's technology naive people. This is a randomized controlled trial from Poland. They do pretty well on MDI. On the left is MDI plus SMBG, 62%, but high time below range, 5%, 5.5%. You put them on 780G, those randomized 780G went from a little higher, baseline 69 and 5.8% below range, 85% time in range. But the really interesting part is their time below range went down to 1.8. So that's the magic combination. More time in range, less time below range. We say carb counting. Goran Petrovsky studied, this is in children and adolescents. What if you just say, take a fixed amount of insulin, just bolus for small, medium, and large meals, and compare that to people, these were randomized to people who were taught carb counting, could do it well. You see, they all started in the mid 40s on the left at baseline, and after 3 months and after 12 months, they both improved greatly. If you count your carbs and do it well, you get up to 80%. But if you don't count your carbs, you just put in 20, 40, 60 or small, medium, large meals, you can get up to 73%. And for a lot of people, that means you don't really have to know how to carb count, because the system is mitigating those inaccuracies because those every 5-minute corrections. And here's just shows you what the fixed versus the flex. The amount of auto corrections is double in the fixed group compared to the flex group, because the fixed group is depending on the algorithm to bring them up to snuff. And this is the A1C. This is the slide I really want to bring home here. This is the times and ranges across many countries in Europe, and on the right-hand side is India, the first 1,500. We heard that mentioned earlier about 1,500 people. It's more than that now. And if you look across this is in over 25,000 people. If you look across the times and ranges, they're all very similar. This is not with the recommended settings. This is all settings. And the time and range in India on the right is no different than any of the Western European countries. So when I was showed this, I see Dr. Mohan is in the audience. I think it was at ADA a year and a half ago. He told me that there are 50 kinds of rice in India. Each one has a different glycemic index, and this mitigates all those different rice. Okay, and this is don't take pictures of this, please, because it's been submitted for presentation at the Endocrine Society this year. And so this is your first look. Anybody's getting at this data. We just looked regionally. So Latin America, EMEA, Europe, Middle East, and Africa, Asia Pacific, and on the right, US. And I've highlighted in blue the time and range. They're really all basically the same. If you use the recommended settings down in this lower part, you get that extra 5% right across every region. So it mitigates the cultures, the behaviors, the age, children versus adults, the knowledge of carb counting, all those things that have been barriers for us initiating these kinds of pump therapy. And now with this 780G, you can mitigate these and get great results. So that's why the American Diabetes Association in the 2025 has actually made the guidelines stronger. They say AID systems should be the preferred insulin delivery method. And when early initiation, including at diagnosis, you've heard about what the UK has done from Parthakar. It's really game changing that now everyone, almost everyone in the UK, will get an AID system. The only barrier is there's not the physician infrastructure and knowledge to start it all at once. And it's now in its beginning its second year. They've secured funding. It's a 4-year program, and this is a very exciting development. So thank you very much for your attention. I apologize for going over.